Uh, Thank you, Dr. Sabnis. As has already been told in the past 3.5 hours, transplantation is a complex surgery. A lot of people are involved in it. It requires a team to do it. And as we all know that there are two major teams, the nephrology, the urology, of course, anesthesia, pathology, and all contribute to it. And now that we begin the session, particularly with nephrology and pathology, it's my pleasure to invite Dr. Rajapurkar. Dr. Rajapurkar needs an introduction. And all of you know that he has been a pioneer in this field of transplantation, not only at MPUH, but even in the country itself. They did it at a time where it was just a dream for many of the people. Very difficult to do in times where even those surgical skills had developed at that point. It was very difficult. Success was very limited. Convincing patients was very difficult. And it's those tiring times that Dr. Rajapurkar persevered. It's a test of perseverance. And the test of perseverance, and it's going to be nice to listen to him about what has been his journey in this last 40 years, what have been the successes and difficulties, how he has overcome. It is always a pleasure to listen to him. Now I invite Dr. Rajapurkar to share his experience over the last 40 years. What do you say?
Thank you very much, Shishir, for asking me to. I don't know whether I'm audible and can you see my screen? I can't see it.
You are audible, but your screen is.
I have clicked the share button. Yes. Let me see once it comes up. Do you see it now?
We see a black screen, but we don't see the slides.
Do you now?
Not yet. But it's written, it is Dr. Rajapurkar started sharing content.
Anyway, thank you very much for asking me to reminisce about the 40 years of kidney transplant at MPUH.
We can see the slides, sir. You may go to slideshow.
Yeah, I've done that. I've just done that.
Come on,
yeah. So first I was thinking, what do I reminisce for 40 years in 15 minutes and who might be interested? Then I thought it's worthwhile sharing the journey. My idea about transplant started during my residency in medicine, at which time we used to do a lot of hemodialysis based on a single machine. And here's my mentor, Professor Wadia, who taught me hemodialysis on this. And this nurse taught me how to do hemodialysis, get access to femoral vein. And this is the technician whom I taught and who still works in KEM hospital. At that time, we were only managing acute renal failures. And there was a problem of we had to send away patients with chronic kidney disease after stabilizing them to either die at home or go to Mumbai or Chennai for getting their transplants. For a long time, KEM had no idea of starting transplants. That is when, after a couple of years after my MD medicine, I was thinking of going to, what do I do further? I was already teaching medicine at that time. And I had three options. One is to go to England as a senior house officer in community medicine, join NTPC as an industrial physician, and finally I saw an advertisement from MPUH as an assistant physician. So I came to look for what future I have. Coming here, I met Dr. Virendra Desai on the first day. Very, very dynamic. And he said he's going to start transplants. And I also realized that I have nobody else to tell me what I cannot do. So after joining MPUH, as Muljibhai sir has already alluded to, I had 3 months training at Aarhus Commune Hospital in Denmark. The professors there were Professor Olfeldt, who was the surgeon. Pasbo Peterson, Hans-Erik Hansen were the nephrologist. So was Dr. Edwin Spencer, and Dr. Kisman Nielsen was the immunology person. He's one of those who was among the early pioneers in developing anti-sera for doing serologic HLA typing. So I learned doing CDC cross-match in his lab. I learned doing fistula from Professor Felbo. I was already doing shunts in my residency. Dr. Peterson was only seen by us visitors there as somebody who's so far away, and which is what their own people used to think. Professor Hansen stuck to Danish, so it was very difficult to do rounds. So one day I was standing in the middle of the ward doing nothing, and this tall American-looking man came to the rounds. He says, "Who the hell are you, and why are you standing here?" So I explained what is the situation. After that, we became good friends, and he started explaining, started doing rounds in English, and requested his team members also to speak English most of the times. And it is during this time that I learned many things from dialysis technicians there, the nurses in the transplant ward, the nurses in the department, Edwin's secretary, and Edwin Spencer himself. Fortunately, at that time, I didn't know what I don't know. At that time, I thought I knew everything. I can do everything that I can. And the other big advantage in Nadia was there was no one to tell me not to do anything. So I could do pretty much anything. And this is Professor Edwin Spencer. He had come to my son's wedding and thoroughly enjoys. He's an Indophile. And that probably was the reason why he became friends with me and taught me a lot. All my transplants. That is Pasbo Peterson, which is the cartoon hung in the department because of his constant and this is the department today which I visited about 2 years ago when I went to the Copenhagen meeting of the EDTA. What are the challenges faced? The first challenge as you have heard from several of the people who went out and wanted to start transplants, that forming a team is an extremely difficult decision to make. A lot of you have to forget a lot of your own ego. You have to accept different opinions, which is not easy to start with. So one is there are problems in the minds, plus what remuneration can you give to your colleagues is another big difficulty in forming a team. But we were fortunate with one full-time person like me, Dr. Virendra Desai in Nadiad, and all other surgeons and all other nephrology and physicians outside Nadiad. I had pretty much a free hand. But now today we are a large team and we do so many things which you already know. The second major challenge was addressing socio-economic, psychological, and legal challenges in transplant. You have to realize that transplant is a huge financial burden to the family. Not only it is a financial burden, it is also an emotional burden because truly altruistic donation within the family also is an extremely difficult thing to accept. And the fear of donation among those who are closely related. In fact, I've seen donors who feel very relieved when they are found medically unsuitable. At least to begin with, there were no legal challenges except to the discussions we had where how do we get a consent from somebody who's himself not going to get benefited from the surgery, but is consenting to a harm, including loss of life to begin with. Can I consent for loss of life to myself was the question. And there was a lot of discussion and debates among the team. We met legal luminaries. And then these legal problems over a period of time were sorted out. Right before the first transplant, we designed the consent form both and decided to not only do a detailed consent form, its translation in Gujarati and Hindi, and then notarize it publicly with a public notary Kanubhai Shah used to come for doing that. The second problem was designing the immunosuppression. So in Denmark at that time, we used to start with 1 gram methylprednisolone given for 3 doses on the first 3 days, followed by 100 milligrams of oral prednisolone to be given, and we would come down to about 10 milligrams of prednisolone towards the end of 6 months to a year. And azathioprine, at that time it was available as Immuran on a black market. Azovan was not available, so we used to get Immuran tablets, often from Royal Chemist in Mumbai, in the Dawa Bazaar in Mumbai, and that is how we used to get that. And so this was discussed, and we just copied what was being done at that day in the Danish hospital, and we brought that protocol here. And you already heard that. And today we can, in the hindsight, say, well, you should have expected that problems to happen. But in those days, as I said, we didn't know many things that we should have known. Then the next challenge we had to face was the diagnosis and management of graft dysfunction. Initially, the graft dysfunction was diagnosed by doing creatinine. And mind you, we did not have IDMS standard creatinine that time. Creatinine was done by hand on a calorimeter by a Jaffe's reaction, and there was always a huge variation, and the accuracy of even creatinine was not great. So we used to look at creatinine, we used to look at fever, we used to look at mic palpation skills for getting graft tenderness, and then we would look at whether the patient has gained weight. And at the earliest suspicion, we would give 3 pulses of methylprednisolone, 3 to 5 pulses. If it didn't work, then we would have considered giving OKT3. And at that time, I would do a peritoneal dialysis to dry up the patient before giving OKT3. From there onwards, we have come to much further. So then when cyclosporin came, the graft tenderness part almost completely went away. So the moment there was an increase in creatinine, what I started doing was to halve the creatinine and give methylprednisolone, and then restart the cyclosporin at about 75% before. As a unit, we had to develop standard operating procedures for many things, operating procedures or protocols. We soon realized that if we do not discuss and do standard operating procedures, not as operating as surgery, but of doing anything in transplants, then your chances are that it will not succeed, whether it is for preventing infections, whether it is for treating infections, whether it is for diagnosing infections or interventions. The thing to do is to make sure that all your units have a standard operating procedure for almost everything that you do. Now, if you face a major problem, start thinking that we have somewhere missed out onto the standard operating procedure. And as you grow more and more senior, I found that more and more protocol violations are done there. Often it is the physician's anxiety which makes us do some protocol violations, and that's something which one should avoid as much as possible. So after all these basics that we sorted out, this was the first transplant, as Dr. Muljibhai also showed. It was brother to brother. This was in 4th April 1980. After 3 months, we lost the patient for sepsis following a ureteric leak. Now, imagine a situation that we are starting the transplant program, and the next ESRD patient I have to convince and tell him that, look, we can do transplants, we have everything available here. But, so what is your experience? Sir, we did 1 transplant. What happened? He is no more there. Promptly, the patient would go somewhere else. But after about 4th or 5th transplant, which the second transplant was about a year after the first. After that went successfully home, then we got established, and then you say a lot of water has gone into the bridge, and today we can do 150 a year. So in the addressing these challenges, designing the consent form was very, very important, where everything including death is mentioned. we worked hard to get the Human Organ Transplant Act in Gujarat. See, the human from 1980 to 1984, there was no law that could have prohibited me from doing anything, and there was no protection for the physician who's doing transplants in good faith. So in Gujarat, we made a lot of effort that time to meet the health minister from the center as well as health minister in Gujarat. At that time also it was Mr. Nalin Patel, and got it passed through Dr. Suresh Vaisha, who was the DMER at that time. So the law was enacted in 97. That law made the transplants more complicated because it put the responsibility of establishing identity and relationship between donor and recipient on the treating doctor. Treating doctor generally translates into nephrologist because he or she is the person who one makes the diagnosis of ESRD, who recommends transplantation, who evaluates both donor and recipient, and it's generally the patients will come back to for every problem, including surgical, back to the nephrologist. Now this added a huge responsibility because establishing identity in our sort of situation and relationship at that time when we didn't really have a very top quality HLA matching, and we were doing emotionally related donors also, is an extremely difficult thing. Then the collection of funds, because apart from the donor as a resource limitation, funds were a resource limitation for many patients. We needed family and patient education. We needed psychological aspects to be studied, support to the patients and their family to be developed. And we had to learn to face the police and the law as and when there was a problem in our unit. I'm fortunate that that was done by Sujata. And one time I jokingly told Anil, who's seen here doing a patient education program, that Anil, if you marry a social worker, that's very good because that makes your life much easier. Sujata collected a huge amount of money, on an average about 0.8 lakhs to 0.8 crore to 1 crore every year on an average for patient benefit, conducted patient education programs, and also did a PhD in psychological aspects of donor. And she was then awarded the Nephrology Social Workers Award in 2011 by the National Kidney Foundation in the US. Forming a team, surgical team and anesthesia, as I said, medical team and improving dialysis quality, which Dr. Muljibhai has talked about. Laboratory, initially there was Dr. Ajwani, who started doing cross matches, and one day he just left. And Sheikh Bhai and myself, later on Ilaben, started to do cross matches. In those days, I could do them myself. I don't think I will be able to do it today. But separating lymphocytes, doing the CDC cross match, I used to manage that. Radiology, you have already seen how Dr. Muljibhai told you about my interest in radiology intervention. It all started with during my residency times when my colleague, the radiology resident, was not very interested in interventional radiology, and a neurosurgeon became very friendly. In those days, there was no CT head. So they used to depend a lot onto the midline shifts by doing carotid angiogram, by a direct puncture of the carotid artery. I'd learned doing that. So that experience came in handy to me. I had also, during my residency, done direct aortic puncture and aortogram there. So when I came here, and I had already been trained on a cardiac cath lab because in those days, a large number of cardiac caths were not done for a coronary angio. It were done for valvular heart disease, which was every ward used to have about half a dozen new valvular disease. So that is how I got into being able to do percutaneous endovascular interventions. We had to train nurses and technicians, both for dialysis, for operating rooms, for laboratories. So we started a technicians training course and got 12th standard guys doing nothing to join us, gave them a stipendiary course for a year. Now, how do we get them recognition? The Nursing Council wasn't very clear, but the Gujarat Technical Education Board gave that. At that time, administration was, as compared to today, very minuscule, but after Virendra Bhai passed away, this landed up into me, including doing everything from arranging duties to negotiating with unions and all that sort of thing also happened. So fortunately, so we now have a great administration team, a large nurses and technicians team. Each of these steps tested your ability, and you had to learn not only the laws, you had to learn how to liaison with various agencies, governmental agencies, non-governmental agencies, donors, recipients, and so on. Immunosuppression, as I said, to begin with, it was prednisolone and azathioprine, and OKT3 was occasionally used, and some IORT3 was also used. Again, there was no plan, there was no standard operating procedure as it is today. Today, we do immunosuppression mostly based on, but I still see sometimes we have physician anxiety as a reason for altering that. Then cyclosporin came. Initially, it was the cyclosporin, not the microemulsion form. Then microemulsion form came. Initially, as I said, we used to get it from Royal Chemist, and patient had to travel to Mumbai and get it. Cyclosporin changed to tacrolimus after Shishir joined us. Azathioprine changed to MMF. Prednisolone still continues. Now, today we use TAC, MMF or MMS plus prednisolone, and you may have plus sirolimus or everolimus. The IL-2 receptor blockers came as inductions, Simulect as well as Zenapex. Zenapex not anymore available. After the ABO incompatibles came, rituximab came, and rabbit ATG started getting used. Therapeutic drug monitoring for CNIs started, which made life much easier, much better. Dr. Mukhopadhyay was the one who originally got it. Initially, we used to do radio immunoassay for. We never were able to establish a HPLC method for TDM, but we did have initially radio immunoassay followed by ELISA, and now a chemiluminescence assay for our therapeutic drug monitoring. And recently, Dr. Hegde has already completed a study of AUC of MPA in patients with transplant to decide onto the dose variability of mycophenolate acid. As I said, diagnosis of graft function initially was clinical only. Ultrasound got added. Graft biopsy. Initially, I was very reluctant to do a graft biopsy. We used to do it with the true cut needle or a manganese needle. We meaning I used to do it with true cut and manganese. There's no guidance, so it was usually the feel of the hand that allowed me. Fortunately, we didn't land up into major problem because of the biopsy. The second question was, how good are we in reading the biopsy? The problem at that time was Advani had already left. So I with Sheikh learned to make the slide, meaning do a biopsy, make a block, sharpen the knife, use, meaning cut the slides, then stain them and see them yourself. I remember very long ago when Dr. Wadia had come to Nadia, then I showed him the biopsies we did. So he just gave a slight smile and says, good for a kidney sandwich, which means it was so thick. And I thought I had cut it so well. Says everything will look proliferated if we did this. So then we had to learn, and from that to today, we have now got everything disposable. When you have to sharpen the knife, see it under the microscope if the sharpening is okay. So those days are over. And now we have got, of course, molecular methods of diagnosis of graft dysfunction. So SOPs and protocols, first we had to, as Muljibhai said, to begin with, we used to have 2 operating theaters in which and the intensive care was just across the ICU. What is today the post-op recovery room and the endotheater, that was the ICU. And we used to go from Muljibhai's room to changing room and then into the OT directly. The small OT on the left side and the major OT. The small OT used to be the donor theater and the large one used to be the recipient theater with some intervening facility for, I used to actually perfuse the kidneys to begin with and then take it. So as far as assisting by nephrology is concerned, I used to assist Muljibhai sir, and for a long time, I have seen every single stitch that he put in for many transplants. Then we realized that we were becoming a picnic transplanters, as somebody else commented that we are picnic transplanters because we used to do transplants on. So the theater used to be stopped after Friday. Friday evening, we would clean up everything, then fumigate the theaters and the ICU for surgery on Sunday morning when everybody would come. So 6 a.m. we used to went off the formalin and then be ready for receiving the donor recipient. Our preparation was not all that great. So theater used to remain closed, and we realized soon that our infection rates are high. And we also, as sir mentioned, after the first vascular invasive fungal infection, we decided to set up a new transplant ward, which is the present transplant ward. And then its air conditioning was designed, and to learn how standards of operation theater should be and so on. So we had to create physical facilities for transplantation. We had to develop protocols for infection prevention, much better imaging. I mean, initial ultrasounds were not all that great. Today, now we have everything added Doppler to it. Also, we have now top quality radiologists who can do a much better job than what, though all of us do it, but having a specialist actually adds edge to it. So I feel very satisfied that a large number of our students, both in urology as well as nephrology, have gone out and taken on doing transplant programs, and some of them are heading transplant programs in other cities, major cities. Is a very gratifying experience to me too. Right at the beginning, when I went to meet Dr. Fjellbo in Denmark, I was assisting him while he was doing a fistula. He says, "Son, what are you going to do after this?" I said, "Sir, I want to learn transplants, and that is why I have come here." He said, "Do you want to do transplants?" I said, "Yes, sir." So he says, "Look, son, it's extremely demanding, and my present wife is the third one. And most of the earning I have goes for alumni payments. So think 100 times before." My luck turned out to be much better on that aspect. I still have the same wife, and we never had to consider all that. But doing transplants is immensely satisfying. See, the urine coming out of ureter brings such a great joy, but it is very demanding also. However, a transplant which does not do well is also heartbreaking, completely heartbreaking. Not only to the patient and the family, but to us also. With this, I would hand over back to Shishir to take it further. Sharing. How do I stop sharing?
Thank you, Dr. Rajapurkar, for taking us through the journey of transplantation. It's very well realized that it's not easy to